thinking about innovations and strategies for management, well, I think there's a kind of myriad of different possibilities. It's a very, very exciting time in the field, and that's just so important for our patients. Thinking at a more basic level, I think the use of big data to analyze large patient cohorts and get insights is really important. And some of the beautiful data presented by Patrick Harrington and Andrea Domenico at EHA concerning a simple risk stratification used by family doctors in the UK, the QRIS3 score. Listeners can dial it up on their phone and look at it, and you calculate, therefore, a vascular risk. They showed that actually outperforms age and thrombosis for ET and PV patients in terms of predicting thrombotic events. But we've also seen the use of big data to pair up, clinical trial comparisons, again, in the transplant field. I think other innovations coming really relate to sort of technology, wearable devices. Increasingly, we're seeing across the field in hemato-oncology. And it was great, again, flying the UK flag to see Patrick's data with the MPN voice collaborative at MyMPN, with almost now 3 million data points showing very nicely fatigue correlating with real biological data such as steps, etc. So we've had a lot of problems with endpoints. Patients have often a lot of problems using a language that clinicians can understand to describe fatigue. And if we can measure it in a different way, that might be helpful. And it may also help us to get more drugs and therapies assessed and approved. But I think the biggest shout is the kind of massive increase in our understanding of biology, how to target that, and then the super exciting data with targeted therapies, especially this year, the CALR targeted therapies, the beautiful data from Insight with the late breaking abstract. That was in ET, of course, but advanced ET often progresses to myelofibrosis, and of course CALR ET more often progresses to myelofibrosis. But we're also waiting for targeted therapies against the V617F mutant JAK2 and against the pseudokinase domain. Hopefully we'll see some data at ASH with regard to that. And then, of course, we've been on the journey for a while, but the combination therapy is also important with, the 72-week data with pelabresib shown at EHA, showing continuing, double the number of patients even out at 72 weeks having spleen as symptom benefit. And then later this year, of course, we've got accrual of data with selinexor. We might see that at ASH 2026, maybe, and navtemadlin. I think it's, super, super exciting time. A lot more collaboration, a lot more interest, but also a lot more granularity about the basic ABC of management and how to do that, which is so important.